Metabolic syndrome. So metabolic syndrome is related to the deadly quartet: insulin resistance, dyslipidemia, hypertension, central abdominal obesity. Dyslipidemia refers to a disorder of lipid regulation in the body. So you have too much of bad lipids, not enough good lipids, and bad things happen. Hypertension refers to high blood pressure, and then central abdominal obesity. Revin syndrome, syndrome X, cardiovascular dysmetabolic syndrome, or insulin resistance syndrome. The diagnostic criteria. So there's the NCEP diagnostic criteria or WHO. So we're going to look at both of these. So NCEP, abdominal obesity, the waist in men is greater than 40 inches. In women, it's greater than 35 inches. Elevated triglycerides, so greater than 150 mg per deciliter. Decreased HDL-C. So in men, it's less than 40 mg per deciliter. In women, it's less than 50 mg per deciliter. Elevated fasting glucose, so greater than 110 mg per deciliter, or high blood pressure, greater than 130/85. The WHO criteria is diabetes mellitus or impaired glucose tolerance. Hypertension, so greater than 140/90. Microalbuminuria, greater than 20 micrograms per minute, or albumin to creatinine ratio is greater than 30 mg per gram. Central obesity, waist to hip ratio is greater than 0.9 in men and greater than 0.85 in women, and or a BMI of greater than 30 kilograms per meter squared. Dyslipidemia, you'd see triglycerides are greater than 150 and or HDL is less than 35 in men or less than 39 in women. This is kind of a fuzzy table, but if you could pause the video and read through this, and you can see hypertension, obesity, insulin resistance, elevated triglycerides, low HDL, and the common causes of all of those contributing factors to metabolic syndrome. The interrelation between atherosclerosis and insulin resistance. So hypertension, obesity, hyperinsulinemia, diabetes, hypertriglyceridemia, small, dense LDL, low HDL, and hypercoagulability all lead to atherosclerosis. So when you have a lot of fats floating around in the blood, especially you have a lot of LDL and not a lot of HDL, you are going to see that can accumulate inside of the blood vessels. If you have a lot of glucose, that can also contribute to the formation of plaques inside those blood vessels. You can have hypercoagulability, so the blood clots more, and that can accumulate to the plaque formation inside of the blood vessels. Once you have atherosclerosis, it will lead to hypertension. It will lead to high blood pressure. When you reduce the volume that is inside, you're going to increase the pressure. So the role of obesity, visceral or abdominal fat versus subcutaneous fat, is extremely important. So obesity is a lot more dangerous and can lead to that metabolic syndrome if the obesity is around the abdomen. Subcutaneous is kind of common, and that can come and go as you gain and lose weight, but abdominal obesity is pretty stubborn, and that's a higher contributing factor to metabolic syndrome. Insulin and leptin. So leptin is secreted by adipose tissue, and it signals the hypothalamus when enough energy is stored. Elevations in both act to suppress the appetite. Proper function leads to the production of subcutaneous fat. But with insulin resistance, the glucose is going to be stored as visceral fat. Other factors increasing visceral fat include chronic stress, cigarette smoking, or genetic predisposition. The contribution of visceral fat to metabolic syndrome. So free fatty acids released from visceral stores, transported to the liver, metabolized to LDL. Visceral fat linked to increased LDL and decreased HDL, and that further promotes insulin resistance. Angiotensin, important regulator of sodium balance. Increased levels lead to vessel constriction. C-reactive protein and IL-6 are also contributing factors to visceral fat. Dyslipidemia, you have elevated total triglycerides, so if you remember those levels greater than 150, reduced HDL, and that depends on whether it's a man or a woman. In general, we say less than 40, but for women, it's less than 39, men, it's less than 35. And small, dense LDL-C, you would see increased levels of that. So fat cells, decreased free fatty acids. When you have insulin acting on the fat cells, you're going to decrease the fatty acids. Those are going to go to the liver. And then from the liver, triglycerides, ApoB, and VLDL release those VLDLs into the body. And then you're going to have the VLDLs converted to HDL, and that's going to impact ApoA1 in the kidney. But when something goes wrong, you're going to have excess triglycerides. If there's insulin resistance, you're going to have increased fatty acids, which is going to lead to increased VLDL, and that's going to impact the ability of the production of HDL. So now you're going to produce LDL instead. LDL is then going to cause issues. So specifically, if we think about the difference between HDL and LDL, HDL and LDL are cholesterol transporters, which means that they're going to take cholesterol and put cholesterol somewhere. HDL is good because it's a transporter that typically takes cholesterol from the tissues and brings it back to the liver to be broken down. It can also bring that cholesterol to different portions of the body to be used and broken down. LDL takes the cholesterol and packs it into your tissues, and it does have the ability to pack it into blood vessels and transport it around in the body. So instead of breaking down the cholesterol accumulates in the body, and that's why we call it like good cholesterol and bad cholesterol. Those are really cholesterol carriers, or low density lipoprotein, high density lipoprotein, and the lipoprotein contains the cholesterol, and the protein portion allows that cholesterol to freely float through the bloodstream. Because if you mix oil and water, they don't mix because you've got fat and non-fat substances. So the only way to transport fats through the blood safely is by attaching it to a protein. So hopefully that all sounds familiar from your biochemistry class, and you're familiar with the process of transporting fats through the blood. So again, dyslipidemia, you have increased triglycerides, VLDL, LDL, and small dense LDL and ApoB, and decreased HDL and ApoA1. Small dense LDL and CHD, potential atherogenic mechanisms. So it causes increased vascular permeability, increased susceptibility to oxidation. Conformational change in ApoB leads to increased circulatory lifespan. So instead of being circulated out or filtered out of the blood, it stays in the bloodstream longer. Decreased affinity for LDL receptor, association with insulin resistance syndrome, and association with high triglycerides and low HDL. Hypertriglyceridemia and CHD risk, or congestive heart disease. Accumulation of chylomicron remnants, accumulation of VLDL remnants, generation of small dense LDL-C, association with low HDL-C, and increased coagulability. It increases plasminogen activator inhibitor, increased factor V2C, and activation of prothrombin to thrombin. Insulin resistance and hypertension, increased catecholamine release, so epinephrine, norepinephrine, and dopamine, increased activity of sympathetic nervous system, leads to increased blood pressure and heart rate, loss of signaling mechanisms controlling vasodilation, and anti-inflammatory effects of insulin, effects on sodium imbalance, water retention, volume expansion, and increased blood pressure. Factors promoting thromboembolic disease in diabetes: increased plasma fibrinogen, increased plasminogen activator inhibitor 1, and increased platelet aggregability. And this is just showing the impacts that different substances in the blood will have on plasmin. So serine protease inhibitor, or SERPIN, inhibits tissue plasminogen activator and urokinase. It's produced by endothelial cells in adipose tissue and stimulated by insulin. Imbalanced thrombosis and fibrinolysis in diabetes. So predisposition to thrombosis, platelet hyperaggregability, elevated concentrations of procoagulants, decreased concentration and activity of antithrombic factors or thrombotic factors, predisposition to attenuation of fibrinolysis, decreased TPA activity, increased PAI1, decreased concentrations of alpha-2 antiplasmin. So diagnosis, physical exam and patient history, obesity or BMI, hypertension, age, ethnicity, menopausal status, smoking, low socioeconomic status, high carbohydrate diet, and ethanol abstinence. Lipid panel, the lipid triad, so increased triglycerides, increased small dense LDL, and decreased HDL. Glucose tolerance versus insulin intolerance. Majority of patients have normal fasting glucose levels, but they also have normal insulin and C-peptide levels. Other markers include CRP or C-reactive protein, inflammatory markers, ESR, fibrinogen, white blood cell count, cytokines, adhesion molecules, uric acid and glutamic transferase, or gamma-glutamic transferase, fasting homocysteine, risk factors for cardiovascular disease. Utility in the metabolic syndrome is unclear. Treatment, diet and exercise, weight reduction, low sodium diet, low glycemic index. So glycemic index is how your body reacts to glucose in the blood. So glycemic index, if you have food that you're consuming, its ability of that food to increase your blood glucose levels. So most of the food that we eat has some type of glucose in it. So even if we're eating a certain type of plant or if we're eating a certain type of animal tissue, there's going to be some type of carbohydrate in there. But if we eat foods that have a lot more protein in them, typically they're going to have a lot less carbohydrate in them. So we can assign each food item that we eat a glycemic index. And that glycemic index, again, has to do with the ability of the food to increase the level of blood glucose in your body. So low glycemic index diet means that you're going to eat foods that do not increase your blood glucose levels. Ethanol consumption in moderation, so you don't want to drink a lot of alcohol. Control of diabetes, pharmacological interventions, hypertension, cholesterol, lipid levels, statins are used for that. Prothrombic tendencies, aspirin can be used for that.